This conference will now be recorded.
So I'd like to welcome everybody today. Happy Friday. It's July 10th, 2020. And I'm very proud to be co-hosting today's webinar with Amy Seigel and Jill Poser of Advocare Care Management. And I'm now going to share my screen with you, and we're going to start today's webinar. So today's webinar is called Solutions and Best Practices for Senior Living Issues: What the Evolving Future Looks Like. So I'd like to begin by having my co-presenters, Amy Seigel and Jill Poser, introduce themselves. Go ahead and unmute yourself, Amy and Jill.
Okay. Hi, everyone. Good afternoon. I'm Amy Seigel. I'm the founder and director of Advocare Care Management. We're a comprehensive and integrated firm servicing Dade, Broward, and Palm Beach County. Proud to say coming up on our 20th anniversary. Thank you, Stephanie, for inviting us to contribute to this very important discussion today.
Hi, and I'm Jill Poser, Director of Life Care Planning, and actually I've been in the director for 8 years and in elder care for 12 years. And as Stephanie so graciously has on this slide, it takes a village. It takes a village to raise your children, and it takes a village to traverse through the aging process. So our philosophy is that we, and the benefits of working with a care management team, we take a holistic approach and we combine a clinical team with the life care planning team to bring about to cover really all the concerns, care needs that somebody has, emotionally, psychologically, psychosocially, physically, functionally, as well as financially. And on the clinical team, we go from the approach of either you're a registered nurse or nurse practitioner. And on the life care planning team, education is equally as important. So everyone is credentialed at the graduate level, either in care management, social work, or gerontology. And then we work back and forth synergistically to make certain that everybody's care needs are being handled. And it's a very important way for our clients then to be able to achieve their goals as they're growing older.
Thank you, Amy and Jill. And for those of you who are not familiar with me, I'm a board certified elder law attorney. I've been in practice for a little more than 29 years. I'm board certified both nationally as well as in the state of Florida by the Florida Bar. And we specifically picked the graphic on the first two slides to impress the idea that people are multidimensional. They're not one dimension. And so when they call you or they call us, they may be thinking of one particular issue, but that issue is definitely going to impact and go off in a variety of tangents. So there's medical issues, social issues, legal needs, financial needs. All of that needs to be balanced. Otherwise, if we have an unbalanced picture, there's going to be some needs that aren't going to be met. So the goals of working together as a team is that we create that balanced picture by coordinating all of our unique professional experience that we bring to the table. I provide legal support, and as an elder law attorney, the legal touches on many of the areas that we're going to be talking about today. And our goal really is to help you and the clients achieve their goals. That's the whole idea about working together as a team. So we're going to begin by talking about the concept of planning to prepare for home care. And Amy's going to start us off with an understanding of what is home health care.
Okay, so as I was saying when we got started, we're going to go over these points. There's going to be facts. Many of you are familiar with these facts, but I think it's really good to kind of review them and categorize them as we all move forward. And as Stephanie says, working together, surrounding the client and their family with supportive expertise and outcomes is what we're achieving in every way. So what is home care? What is home health care? Home health care is the concept of providing the overall clinical care and functional activities of daily living in someone's home. That's the simplest way to place it. And then in the home care, we're looking at who can, right now we're looking at, and the work that we do as care managers, the feasibility of returning home versus going to a skilled rehab facility. How do we determine that? So we have to really look at asking many different questions. We have to look at each factor. Does the patient require more than one caregiver to transfer them? Can the clinical care be provided in the home, such as IV therapy, wound care? Is there a tube feeding? Can these things truly be maintained in the home? Can the patient afford around-the-clock private assistance at home? Do they need middle-of-the-night care? Health insurance does not always cover around-the-clock in-home care, and that's where families really need to be guided. They don't understand what the long-term care insurance benefits are covering. What does that entail? Is there therapy in the home allotted to that client? Have they used up most of their long-term care policy? How can these benefits be managed? All these questions have to be considered when you're discharging a client. The differences between Medicare home health and private pay. That is a really big question. Medicare covers mostly the skilled care and a limited amount of custodial care. Does everybody understand what the difference between skilled care and custodial care is? Can I just get a shake of a head or okay. So, a lot of families do get confused about that. Medicare covers the skilled care. Only a little bit of custodial care is provided under Medicare. Private pay custodial care is the care that a nurse's aide provides to a patient with tasks that include ADLs and instrumental ADLs. ADLs are bathing, dressing, toileting, transferring, feeding. Instrumental ADLs are medication reminders, companionship, mental stimulation, so important, shopping, cleaning, and laundry, meal prep, administration tasks, telephone communication. That's a really big instrumental IADL right now because of COVID and not being able to communicate in person. So this is a task that patients are getting assistance with, and it's an important one for socialization and making sure that people are not becoming isolated. Telephone communication, transportation. So those are a little bit of the differences between what Medicare covers and what private pay covers. The protocols of home health agencies during COVID-19, without going too deep into that, because there is a ton of information and there's different protocols for different levels of agencies, but basically right now, all the agencies and the registries we are finding are following the guidelines of the CDC for home health entities during COVID. These are not the steadfast laws. There's not mandates on every last item for nurses' aides and nurses going into homes, but there are guidelines set out by the CDC, such as the staff stays home when they're feeling ill. Temperature checks are done prior to going to a client's home. Wearing masks and gloves, as people are saying, PPE, that's very important. Keeping distance from the patient, even if you are caring for the patient, keeping your distance as much as possible. There are certain tasks that a nurse or caregiver does that they can only get so far. But when they're not doing those tasks, the guidelines are saying, stay the distance. Negative tests, if there is a situation where a caregiver does obtain a virus, they're saying that they need to stay home, quarantine, and not to return to work until they're testing negative and that they've a 14-day quarantine at least. So that's the overview of the COVID policies without getting too far into it. What's a home health agency compared to a registry? So that is a huge umbrella of information. And again, without going too deep into every last aspect of the differences, I'm going to give you the summary and the overview. So a home health agency, and many people, we label these things, and I find that when we're talking to families out of town, all of us in the industry will say HHA, CNA, you know, and the families will be like, what's that? So we all know the terms, we all know the little abbreviations, but sometimes the families don't, and we have to remind ourselves, not everybody understands that. So a home health agency, or an HHA, is an organization that can provide both skilled and private custodial care. The staff and the caregivers are all employees of that organization. The payer source can be Medicare if the agency is Medicare certified, and most of the Medicare agencies and anybody that is listing themselves as a Medicare skilled agency is certified to do the services under the Agency of Healthcare Administration. And the home health agency can take long-term care, private pay, VA benefits. Many of the agencies, depending on how big or small they are, will accept assignment of benefits. Some agencies do ask the clients to pay a certain portion, and then the rest can be billed, and that is all on an individual basis. A nurse registry, on the other hand, is an organization also licensed by the state to provide independent contracted caregivers. The staff in the office are usually employees, but the caregivers are independent contractors. They have to maintain continuing education. They have to have background checks and criminal screening. Both the agency and the registry have to, by law, maintain those guidelines. The payer source for Florida registries is long-term care, private pay, VA benefits, and some Medicaid. Registries do not provide care under Medicare. Screening, background checks, and insurance are all carried similarly now in both different types of organizations. State of Florida and also Palm Beach County has implemented another rung where all the caregivers, whether you're with a registry or an agency, have to become listed with the county, fingerprinted, and go through another rung of Palm Beach County qualification and criteria. Okay, so that's it for that. Why should you hire a home health agency or a registry compared to directly hiring an independent caregiver? Now, I have about 3 hours on this, but I'll just give you the 4-minute overview. So this is a very, very common occurrence. Families are pressed with cost of care, long-term care. Their family members are living longer. They're quickly utilizing all their long-term care benefits. Finances are challenged sometimes. So when a private caregiver meets a family and offers them what they consider to be a good deal, and the family's called 3 or 4 agencies and is really grappled with, wow, what should we do? The private care, the person that's my mother's neighbor's cleaning person who's now wanting to do home care and skilled care and, you know, private duty care, nurses aid care, that person's offering us, you know, $3 less an hour, and this sounds like such a good deal over time, and we can have more hours. But what they're not understanding is, are they able to complete all the state and federal background checks themselves? The agency and the registry all meet strict ACA guidelines, as I just spoke about, in order to ensure certifications, licenses are up to date, including continuing education. They're not understanding when they're hiring private direct employees that the assignment of benefits from a long-term insurance company or Medicaid are paid to the licensed agencies directly. They are not going to be paid to private people. If a patient and a family hires a private direct hire, They have to adhere to government and state employment laws, overtime and labor parameters, and there is little recourse if a caregiver is dishonest or unreliable. Many families will think it's a money-saving measure, as I said before, to employ a direct caregiver, and there is no caregiver to quickly take over. This is the most common occurrence that happens when the family goes, oh my God, I should have listened to you. When it's 9 o'clock on a Saturday night and the next shift is supposed to come on at 10 or 11, that there's no the private caregiver and her network of fill-ins is exhausted. What happens? That family is faced with a no-show situation. There's no caregiver to quickly take over the shift for that fragile or vulnerable patient. All caregiving organizations, both agency and registries, are structured to handle caregiver call-ins, replacement shifts, and are on call for 24/7. So that's my abridged version of that. We can talk about that later if anybody has any more questions on that.
Thank you, Amy. So now we're going to turn to planning to advocate for quality care, being that legal advocate. Now, in the ideal world, we would really like everybody to have certain legal documents in place so that when decisions need to be made, they can be made easily without a delay in time. So I'm going to touch upon two very important documents, the first one being the designation of healthcare surrogate. And this is how we name a medical advocate for ourselves. So if something affects our ability to speak, to understand, to use good judgment or reasoning skills that affect our ability to make an informed medical decision, we want to have somebody that we trust, that knows us, to be able to be our advocate. So it's very important that before you go see an attorney, that you have a conversation with the people that you are thinking of naming as your surrogate. Make sure that they are on board and are willing to take on this responsibility when the time comes. When you're thinking of who to choose, there are some really good criteria. The first is picking someone that you trust, somebody who is going to make themselves available, and available does not mean that they must live in the same city, town, or state where you are. With today's technology, such as the video conferencing we're using now, it's very easy for people on one side of the country to be able to serve as a healthcare surrogate for somebody living in another state. You might also want to think about their skill sets. Now, this does not mean that if you don't have somebody to choose from who's a nurse, a doctor, or a healthcare professional, that you have nobody left, but sometimes it's more about how have you seen people respond or react to stressful situations in their life. So think in terms of people you know who seem to stay calm. They knew the right questions to ask. They got second opinions. Those are probably the more likely people that you want to have a conversation with and consider naming your healthcare surrogate. Your surrogate is going to be able to do all the things you would when you're able to speak and you're mentally aware. So they're going to be able to communicate with your doctors, call in a second opinion, speak with a specialist, give access to your medical records to be reviewed. And if they do not like the facility where you're currently located and they feel that another facility or hospital would provide better care, they have authorization under the law to initiate your transfer and discharge. Now, when do they make medical decisions is very important because Florida 2 years ago decided to change its healthcare surrogate law. And now clients who have an attorney create this designation for them get to make two very important choices that are written in the document. The first choice is when they would like the surrogate to actually begin to act for them. And the choices to choose from are either immediately or only when the doctor determines that the person lacks the ability to give informed medical consent. And what's nice about this choice is that younger clients might take the second choice, which is only when they lack the ability to give informed consent, whereas an older client may feel more comfortable allowing their surrogate to be involved now. Also very important in the healthcare surrogate document is permission to have access to confidential medical information. This is what we refer to as HIPAA information. For example, this could be a test result. So the Florida law that changed 2 years ago also made it possible for clients to choose when they would like their surrogate to access HIPAA information. They can either choose to have it accessed now, as soon as the document is signed, or only when they lack the ability to give informed medical consent. Now, there are several other types of medical advance directives that are important to consider. For example, if you're interested in donating organs or perhaps tissue that might be able to be used to help another person for a transplant or perhaps medical research and study, you might then want to do a declaration of organ donation. You might also want to consider having a living will. This type of medical advance directive allows you to put in writing your preferences for end-of-life care if you're diagnosed with a terminal illness that's going to shorten your normal life expectancy. So it will give you the opportunity to let your surrogate and your treating physicians know how you feel about artificial nutrition and hydration, pain medication, hospice care, do not resuscitate orders, and many other decisions that may need to be made for you. The do not resuscitate order is actually a form created by the state. It is not a document created by attorneys, and it must specifically be printed on yellow paper so that if 911 is called and they come to a person's home or a facility, they take just the first few seconds to locate this document and ensure that it was properly signed in order to honor the person's wishes that they are not to be resuscitated. And the last advance directive to consider is what we call a declaration of funeral designee, which simply means naming somebody that you trust that's responsible to implement if you've already made funeral arrangements while you were alive, or if you didn't implement anything, then to go ahead and make those arrangements for you. So it allows you to designate the trusted person who has permission to do this, and it allows you the opportunity to indicate in writing whether your preference is to be buried or cremated. And now we're going to talk more about planning to advocate for quality care, your medical advocate.
Okay, so many times the clinical team in a care management organization can serve as a client's medical advocate. We must pull together critical data and information to assist the client and the family in making a decision or selecting a certain plan of care, and it takes many years of diverse medical experience. We need to have the knowledge to decipher the medical data. It's super important to anticipate the future medical needs and pre-plan, because not all families understand what's coming next. We have to be proactive in organizing and managing the medications. We have to be able to communicate with all parties to ensure complete understanding. Sometimes we coach the family in their role as a medical advocate so they can assist in making the most informed decisions. Sometimes this cannot be done by family alone from afar and without the expertise. Understanding the situation, the treatment options are very important. Communicating with all the care providers, the physicians, to determine whether the patient should be seen by the physician. Can this wait for a weekday? Do we need to do an emergency ER visit? Something very interesting happened just yesterday. We're seeing now during these times of COVID, where we're all as professionals having to act in a way where it's more urgent and things are coming up day to day and the situations are changing. And what happened yesterday, the protocols might not be the same for today. So just yesterday, we received an out-of-town call from a physician and his wife who have their mother here in South Florida, and they're trying desperately to keep her out of the hospital during COVID. And they understand the significance of her being alone, older, memory disorder, lying alone in a hospital bed in an emergency room, and then subsequently potentially in a hospital room. This is not somebody that could manipulate a cell phone and communicate with her family. So they're doing everything possible to try to maintain and manage this situation from afar. And they're even medical professionals. However, what precipitated the call yesterday was the patient has been homebound, had a fall, the elder client had been taken to several doctors this week, and the family was talking to the doctors after each appointment. No definitive diagnosis was made. The patient was still very weak and lethargic up until yesterday and being taken care of at home with a caregiver who they considered to be a very good caregiver. The family was desperately trying to keep their parent, as I said before, out of the hospital. They felt as though they could not ascertain what was going on at home, and she is not getting any better. And all the doctors are saying is, we can't find anything wrong, and the blood work is coming out fine. Thankfully so, they called the Advocare. The RN care manager yesterday went and made a face-to-face visit to the home with her PPE and ready to interview the nurse's aide and assess the patient. And it was discovered that the client had been taking 2 similar antibiotics, strong antibiotics that were prescribed by 2 different physicians with similar names and functions. Having the correct information, as the slide says, to provide medical providers is essential in the correct diagnosis and a safe care plan.
So we talked a little bit about the importance of having legal medical documents, with the goal being that our medical decisions can be made privately by people we trust without us having to go to court and go through a process of becoming a legal guardian. It's equally as important for us to take the time and put together certain legal documents that allow people we trust to make our financial decisions as well. And probably the most frequently known document that people hear about in the news is the durable power of attorney. This is a type of document that allows you to give somebody you trust permission to access your assets if you're incapacitated. One of the nice things about the durable power of attorney is that it is not making somebody else an owner of your assets, which means that your assets are protected even if the person you name as your financial decision maker were to have their own financial mishap. Perhaps that individual gets a divorce, or they have a business that does not do well and they have to file for bankruptcy. Those events are not going to affect your assets in any way because your agent is not an owner. They're merely being given permission and a responsibility to handle those assets for you. So just like we discussed with the process of choosing a qualified medical decision maker, we would want to apply those same criteria to determine who should you name in your power of attorney. But it doesn't stop there. This inquiry goes a lot deeper, and it's important that you share with the attorney what your assets are, as well as the ownership, because this will impact how we write the document and whether or not the person you're going to name as your financial decision maker will actually be able to access the assets. Recently, people are gathering more digital assets. So these are things like our social media accounts, our accounts that we access through the internet, such as our bank accounts, our investment accounts. These also must be identified and they must be addressed in the document. So it's important to understand that there is no one-size-fits-all. The durable power of attorney needs to be tailored to each individual's unique circumstances, which includes their marital status, their family dynamics, what the assets they own are, and where those assets are located. So when we think about who to name in this trusted position, again, focus on the word trust. We want somebody who has the ethics and morals that we have. Skill set is also very important. We want to think in terms of a person who is organized, because not only must they now take care of their own assets, they have to take care of ours. So we want somebody who's organized, who has good record-keeping systems, and then most important, that they are going to make themselves available when the time comes that we need them to begin to act for us. Now, if you're attending today's webinar and you're thinking of a specific person, perhaps a relative or a neighbor, that is going through the aging process, but they don't have either a designation of healthcare surrogate or a durable power of attorney, and you're concerned that it may be too late because their mental capacity has changed, then the option we would explore to make financial and medical decisions is a guardianship. And in Florida, we have two types of guardianships. The first one is called a voluntary guardianship. And as you can tell by the name, it is for those people who still have a level of awareness and recognize that they need assistance to carry out their financial day-to-day decisions. This guardianship is only for financial decision-making. It will not give the individual the ability to make medical decisions for the adult. The second kind of guardianship we have in Florida is called an involuntary guardianship. And this is used when we feel that somebody lacks capacity, either cognitively or physically, to care and make decisions about their health, their well-being, where they're going to live, as well as taking care of their financial affairs. To initiate an involuntary guardianship, we file papers with the court, and the court in turn will appoint a medical examining committee to go out at different times to evaluate the individual and make recommendations to the judge. In addition, the court will appoint an attorney out in the community to be the attorney for that individual and make sure that their rights are being respected and are not being unnecessarily taken away. About 4 weeks after the papers are filed is when we have the hearing, and we go to court with the individual, their attorney, and the proposed guardian. The guardian who is being proposed must pass a very thorough background check that is a combination of a criminal background check where their fingerprints are sent through FBI records and Florida Department of Law Enforcement records, and they must also go through a civil background check as well. And Florida, as well as many other states, does this to ensure that the right individual is being appointed as guardian for the incapacitated person, and that person will be protected. So now we're going to talk a little bit about the life care planning approach and how it is so important when we advocate for quality care.
In 2008, AARP joined with the National Association of Home Builders and did a massive survey to understand this phenom that started occurring because of the baby boomers turning 65. And so what they discovered is that over 90% of the elder population wanted to age in place. What does that mean? So in aging in place, at any time in our lives, frankly, we always look at our life as a plan, right? We budget into our lives along the continuum. So we have children and we start thinking about putting away money for college. We start thinking about putting money away for retirement, for vacations, and so on. So now you've come to this stage in your life, you've retired, and you feel like you've planned for that, only you really didn't necessarily understand that in that plan that the use of money and when you would execute the use of that money would become different. So it's all about looking at somebody's changing care needs in anticipation of even further changing care needs and how you're going to use that money to address changing care needs. So it is a collaboration, frankly, between medical and financial to bring the total solution together. The hope actually is that it will be proactive versus reactive. But oftentimes what happens for all of us is that we never really envision that that day will come. You know, man plans and God laughs, as we say, and life turns so quickly when you least expect it, and then you're there. So the hope is to plan, but oftentimes it becomes maybe not catastrophic, but sort of on the continuum that could lead to catastrophe. The practices are the same, whether it's catastrophic, it's crisis planning, or it is pre-planning. The concept is the same. You have to address the use of money in relation to changing care needs. You may have to use different strategies moving into crisis planning, and that's a lot where life care planning looks at working with specialized attorneys, such as an elder law attorney, so that we can help people, you know, as far along the continuum in crisis as we can. But the practices of this do not change. The use of money and addressing what people can afford. I say every day, follow the money. You cannot have a plan around your life without understanding what is available to you and how you can use it. So even something as simple as someone comes to us, right, and they say that they have all these, you know, they're sitting on assets. Okay, but the asset is solely in an IRA. And IRA, typically you're taking required minimum distributions. Okay, if you take more than the required minimum distribution, then there are tax implications to that. And what if there's another spouse and the care needs are different, and this spouse does not have dementia and is fully capable and looks like life will go on for many years without any issues. So there's lots of planning that has to be thought about from the perspective of what people have, as I said, the use of money in relation to changing care needs, so everybody's needs are being met along the way. Now, in terms of the qualities of an effective life care planning advocate, actually, we're, you know, from our perspective, and I can only speak from our perspective, you know, we're all about education. And the more education you have, the better. Because to really understand this space, meaning the senior space, there's a lot that goes into aging, and there's a lot of emotion that goes into that. There's a lot of psychological implications to that. People can be planned throughout their entire life, and all of a sudden their needs are changing. It happened in my own family. You know, my mom fell 2 weeks ago, and she went from being a person who said, I'm never wearing an emergency pendant, to all of a sudden thinking, wow, okay, that might be a good idea, because she actually fell and hit her head, full blown hit the whole left side of her head and her face. And it was very frightening when we landed in the emergency room because she had so much pain in her head. So things change and how you think about it emotionally changes. So that's a lot of what happens from, in dealing with clients at this stage in life. And so to be educationally credentialed and understand and have the training to look at it through the lens of a care manager or a gerontologist or a social worker helps people to be able to sort of ease into these transitions, because the professional is anticipating all the what ifs. And money is a funny thing. You have to learn about the way people have relationship to their money. There are good relationships with money, and there are toxic relationships with money, right? And people become fearful at times. So what is your use of language? How are you able to guide people so they feel like you're walking with them and you're helping them to embrace these changes in their lives? So we're a big fan, as I said, in being educated to be in this space, and then having an understanding of the life care planning practices, and to be trained in that as well.
So now we're going to explore planning to qualify for government support services. You heard Amy speak earlier today about how different sources may or may not pay for home health care. And Jill just shared with us the importance of knowing what the income and asset resources are in order to create a viable plan to care for somebody, whether it be in their own home or in another home. So we're going to touch on a few of the available resources, the first being long-term care insurance, which is a private insurance policy. Preferably, this needs to be purchased when somebody is younger, because the premiums are lower, and the premiums will get higher as we age, because there's a greater likelihood that we will live longer and therefore need to make claims under the policy. Now, traditional long-term care insurance policies will cover home health care, possibly assisted living, and skilled nursing. The more recently developed policies will be a hybrid of a long-term care insurance policy with a regular insurance policy. And the reason these were developed is that some individuals are not able to pass the medical underwriting criteria, especially if you have a pre-existing diagnosis or a pre-existing illness. So this is another option to the traditional long-term care insurance policy. In addition, some individuals might have a private disability insurance policy, either through employment or that they purchased on their own privately. So this will become a replacement source of income should somebody younger not be able to return to work and need to pay for home health care services. One thing to be aware of is that if you do have a private disability insurance policy and you apply to Social Security for what is called Social Security disability benefits, once you are approved for those Social Security disability benefits, it is very possible that the amount you're receiving from the private disability insurance policy will be lowered. They will take into account the amount that Social Security is paying you. Social Security disability insurance is going to be available if two important criteria are met. The first is the medical, which means that Social Security has to determine that the applicant has an illness or disease that affects their ability to be substantially gainfully employed in the position that they previously held. And this decision is made through a combination of having their doctors review your medical records, and if necessary, they may require the applicant to be evaluated by their own doctors. The second criteria, which is just as important, has to do with whether the applicant has accumulated 40 quarters of payroll taxes in the system. This means that you had to have worked the last 10 years and a quarter is earned for every 3 months. So during a calendar year, you can obtain a maximum of 4 quarters. Now, if somebody is being paid, as we refer to the phrase, off the table, they're paid cash, there are no payroll taxes being reported to the federal government, then you don't accumulate those necessary payroll tax quarters. And this is where it can be a negative impact for somebody that is hoping to obtain Social Security disability benefits. So if the medical requirement is met and the individual has the 40 quarters of payroll taxes, then they're going to be approved for Social Security disability benefits. And this essentially means that you are going to receive your Social Security retirement benefits early, prior to the normal retirement age. So for an individual that is receiving Social Security disability benefits, when they reach the age of retirement, Social Security will send them a letter letting them know that now for record-keeping purposes, they are no longer receiving disability, they are receiving retirement benefits. What's very important about qualifying for Social Security disability insurance is that approximately 2 years after you get approved, you will automatically begin to receive Medicare Part A benefits. So Medicare Part A is going to cover our hospitalization, durable medical equipment, and hospice services. We then have the ability to buy in and pay a premium for Part B, which is mostly the coverage of our physician visits. So Social Security disability becomes an important pathway to provide people with Medicare, which will give them some of the home care services that Amy and Jill have shared with us today. Now you might be thinking, what if somebody doesn't have the 40 quarters of payroll taxes? What happens? Are they just denied and that's the end for them? Well, the answer is no. If they don't meet both criteria, then the Social Security caseworker reviews the application from another perspective, a program that is called Supplemental Security Income. And the acronym for this is SSI. So they're still requiring the disability, but there is no requirement for payroll taxes. However, the individual applying must have very low income and very little assets. So the SSI program is different than the Social Security disability program because here we are limited for income and resources. Somebody applying for SSI must have less than $2,000 of countable resources, whereas somebody who is applying and becomes approved for Social Security disability has no financial limits at all. So they can have assets, they can have money in the bank, money in investments, and that is not taken into account at all when they are applying for Social Security disability. The other thing to recognize about supplemental security income is that when a person is approved for this program, they automatically are approved for basic Florida Medicaid assistance. So keep in mind that certain programs work in pairs. Social Security disability gives us Medicare, and supplemental security income gives us Medicaid, which is another form of health insurance coverage. So Medicaid is going to help cover the cost of certain health care. The benefits are paid directly to the healthcare provider, not to the recipient, whereas the SSDI and the SSI programs actually pay us the monthly stipend that we can then use to contribute toward the cost of our care. And it's very important that we don't forget to ask if an individual is a veteran or perhaps is married to a veteran, because there may be some benefits available to pay for healthcare services through the program called Aid and Attendance Benefits. And this, unfortunately, is still a very secretive program that you don't hear a lot about, but it enables the veteran or their spouse or surviving spouse to receive a monthly stipend to help pay for healthcare services if they meet both medical requirements and financial requirements. So I'm hoping that you will join me for another webinar where we go into depth about veteran aid and attendance benefits and how to obtain them.
So when we talk about planning a transition into a community where, as it states here, we're looking at all the different types of communities. There's independent living, there's a continuous care retirement community, which is a buy-in opportunity, there's memory care, and there's assisted living. And there's a newer model even within the assisted living where you can age in place in your apartment, and the facility is at a higher licensing so that you can maintain your apartment until potentially you need memory care. That all said, you know, in terms of the way, you know, we're transitioning into communities now in the midst of COVID-19, things are different. And so you know, the protocols are changing, and they're changing on a pretty consistent basis. So what was relevant in March and April is now sort of changing in June and July. So for example, there's it's the ACA's Emergency Rule 59 AER-20-5 that states that if for skilled nursing and assisted living, visitation is prohibited except for family and friends during end of life situations or for the purpose of healthcare or legal services. So healthcare meaning you must be classified as an essential worker. So those are the staff in the facilities themselves, those are hands-on healthcare workers, those are care managers, all considered to be essential workers. So that has supposed to be very daunting for families, right? If it's not an end-of-life situation, you are not eligible to visit potentially with your loved one. Recently, some of the hospitals have eased back on that, and they're allowing one visitor a day. It's far and few between, and that visitor has to be the same visitor. If you leave and come back, it still has to be the same individual who came in the morning. In terms of the way the facilities are having to communicate with families, the expectation is that they are communicating on, you know, a regular basis. What does that mean when there are, you know, when there are so many urgent situations emerging, you know, and the facilities are not used to having to make this number of phone calls because family members are no longer allowed in? It's become, you know, much more daunting. So the goal is, you know, that there's communication pretty consistently, but a lot of that communication now is coming through telehealth, right? And when the nurses and, you know, the staff can get to these phone calls, the goal is to to have participation in care plan meetings. But again, these care plan meetings, you are having to do this through telehealth, and so it becomes much more overwhelming. It's the intention of all the facilities to maintain these meetings consistently, but as I'm, you know, sharing with you, it's become a lot more difficult. Where it's easier for a professional, by example, is because the professional knows the questions to ask in a very rapid and timely manner. So it's easier to get to the end of a phone call and achieve the outcomes that you're looking for to be able to bring it back to families. So the staff in these facilities have embraced actually working with, you know, outside support, for professional outside support for speed of, you know, for ease of communication and speed of communication. So in terms of facility transparency, all the residents and staff are being tested for COVID-19. And the what's now having to happen is that the staff, in any of these facilities are self-included as essential workers. Anyone that is considered an essential worker now needs to be testing every 2 weeks. The challenge that we have here in this testing is that it also takes a few days to get the results back. So you're testing, you have to wait for results. What happens in the interim? How are these facilities staging their staff requirements, in terms of waiting to get results back? So there's a lot that goes into behind the scenes, for all of these facilities that, families aren't necessarily understanding either, and you can't blame them. They want to have the information about their loved ones. The other factor that is occurring, Stephanie, in terms of no outside activities. So a lot what's happened in some of these facilities is that you need to stand outside a window, right, or outside an entryway, and you can wave to your family members. So at least there's some opportunity for some type of connection. Not at the hospital level and not necessarily at the skilled nursing level, but in assisted living and in the communities, that's been, a huge positive, wherever family members are local. But if you're not a local family member, it keeps changing. The regulation was supposed to have where you could have visitation starting July 8th. Okay, now there's no visitation as of July 8th, and now we're looking at an opening date for visitation of September. So it keeps pushing back because in Florida, we keep having an increase in the number of cases, and the facilities have an obligation and a responsibility to keep their residents safe and sound. In terms of facility reporting requirements to families, what the Florida Department of Health is requiring is that there's an expectation of facilities to be reporting daily to the health department with COVID information. So if there is an increase, of positive cases, tests performed, deaths at long-term facilities, that all needs to be reported to the Florida Department of Health, so that they can be uploading and reporting online on a daily basis. However, my understanding is that in the state of Florida, the hospitals are not mandated reporters of current COVID census. So there's a little bit of a complexity and a disconnect in some of the reporting. But the facilities themselves, in terms of reporting to families, obviously the goal is to be reporting timely. So facilities are sending out letters on a pretty timely basis, as soon as, if they have a COVID, a positive COVID resident, right? And so in terms of the actions to mitigate, that's complicated, right? Everybody is having to wear PPE, right? Everybody is now mandated to test every 2 weeks, but you can only do the best you can do, because there's no guarantee of outcome. Once somebody leaves the facility, right, a worker leaves the facility and goes back into their private life, as much as everybody is looking to be careful, right, and control the variables, there's no way to know how somebody is or isn't living their life, or how somebody is being exposed, to the virus. So the CDC and, working in tandem with each individual state is doing their best to mandate regulations that will be somewhat more preventative. My understanding, Stephanie, is now that it's sort of changed, because they're saying, in the current information is that the Florida Department of Health is doing their best to upload information on a daily basis with all of, the changes that are occurring in terms of the numbers and so on. In terms of access to testing, so that's become interesting too, and we're discovering a lot of challenges, as we're going into hurricane preparedness for, for our clients that need to evacuate during a hurricane. So now the requirement has been, in order for you to evacuate from your home and to be admitted to an assisted living community, you had to be tested 24 to 48 hours ahead of admission to the facility. But now with the increase in the cases, the rapid turnaround of this test result is not as easily attainable. Okay, so now we're having to push back and say, well, can we, the results are more likely to come in within 72 hours. Are you accepting the admission? There have been some testing facilities that are telling us that they're 7 to 10 days out. Okay, assisted living facilities don't want to accept admissions with testing that's been done 7 to 10 days prior. So COVID-19 is having a huge impact on the way we're all having to, assist families, and we're all having to change our expectations and live much closer to the, to the moment, to be in concert with what is actually occurring. One last thing about testing, actually. So the issue you have is that there's privatized testing and there's testing that's being managed on a county basis. Where that sort of becomes complicated is that, yes, there's no cost if you get your testing through the county. However, if you need a quick turnaround, there's no guarantee of outcome. The county is doing their best, but with the increase in COVID testing and cases, the outcomes of testing results could take anywhere, from 4 to 7 days. If you're trying to plan, okay, for any type of crisis planning, let's say like a hurricane, you can't depend on the county for the test results. It's not that the test result isn't accurate, it's just not necessarily timely. So there are costs involved in terms of testing privately. Some can afford the cost. Some are having a harder time with the cost. Some can put it through their insurance. Some the insurance won't cover. So there's a lot of factors that are going into addressing all the needs of, of clients as it pertains to COVID-19.
And Jill, just to add to your very excellent points, what we learned this week is some of the testing sites, the labs that were advertising as private service would come to your home, would allow you to drive up and be tested upon appointment in your vehicle. What those private sites have not revealed is that they too were using the 2 county labs that all the tests were funneling into. So now your client is paying $225 or $250 for a private test so that they don't have to wait on the county line in a car or in the hot sun. But what they're not telling people is that it's still going through the 2 main labs, and it's still, oh, so sorry, we took your specimen quickly, but we're not able to get your result due to the influx of so many people needing testing. And this happened to one of our clients just yesterday. So it's fearful. The results took 9 days.
Thank you, Amy, for sharing that, and thank you, Jill, as well. So we don't want to forget about the importance of federal laws that have been in place for many years to protect residents of different residential communities should there be a request that they be transferred or discharged. So we want everybody to understand that a resident by law is entitled to a 30-day written notice and to have the right to appeal. They also have the right to choose a location of the transfer, and the transfer must be reasonable to meet their needs. It's important for people that have any kind of cognitive impairment that they receive proper preparation prior to being transferred and discharged so that they can maintain their orientation and so that the transfer is as safe as possible. Now, there are some exceptions to a community providing a resident with prior notice. And one of these is based upon current circumstances, which is that if a resident has tested positive for COVID, there is that ability to have them transferred to a facility that is specifically taking care of COVID positive patients. There's also the exception that a resident who has tested negative for COVID, if there's a need to, transfer them to a facility that is completely non-COVID. The other exception is if the facility feels a transfer is necessary so that the resident is observed for that 2-week, 14-day period that Amy talked about earlier to make sure that they are not testing positive and could possibly then transmit the virus to other people that they come into contact with. So Jill and I are going to walk you through the conclusion to today's webinar. And our first recommendation is to make a list of your goals. This is very important. And as we explained in the beginning, people are multidimensional, so there's going to be more than one goal. It may be quality of life. It may be the desire to stay at home. It might be the desire to be close to family members. And it can include many other goals in addition to that. Jill?
So clearly identifying your financial resources becomes critical. And, you know, in our world, you know, we are not investment advisors. We don't see ourselves that way. But what we do encourage people to do is before they even get to this piece, you know, of their lives, we talk about it from the perspective of creating what we call a vital document inventory, where you are identifying all aspects, financial aspects of your life. So whether it's your long-term care policies, it's your life insurance policies, it's all your investment accounts, it's your advance directives, everything that speaks to your financial life needs to be in one location, preferably in either a safe or in a fireproof box, in a location in your home, actually, where all the people involved who need to know about your life, you know, in terms, your attorneys, in fact, you know, specifically, okay, have access to these documents, not that they go in your, you know, not that they're in the bank, in the vault, so that if there ever is a, God forbid, which we never know when that will occur, you have complete access and disclosure of all the information about your life that would be necessary for long-term planning.
And then because people are multidimensional, it's important that we bring together a team of professionals that can address all the needs and help the client achieve all the goals, including an elder law attorney, an aging life care manager, a financial professional, perhaps a CPA, as well as others. And as Jill has stressed, it's important to have a support network. And so we'd like to close with having everybody think about what it is that makes you feel empowered whenever you have to make a decision in your life. And these are the things that we want people to think about as they're actively planning to age and decide how they want that aging process to look for them. So Jill, would you walk us through these steps?
I'd love to. So in terms of it being holistic, right, and this is throughout your entire life, but there's a great sensitivity that must be, you know, must be afforded this time in your life when you're getting older. You've earned the privilege, as I like to say. So we look at people mentally, we look at them emotionally, we look at people spiritually, physically, and we also have to address the financial aspects of somebody's life so that we're covering it from all bases. And you know, what I've discovered in all of this is that when we're talking about the senior space, we always talk about it as if it's over there, right? And we're over here. But the truth is, we're all people, and if God will be good to us, we all will step into that space in life. So it's a lot about, how do you want to be treated? How do you see yourself? And, you know, what would you like your experience to be, you know, in order to feel empowered in your own life? Those are the types of people that you want to surround yourself with, so your experience as you age is kind and gracious, not that you're over there and those people are over here, if that makes any sense. I hope it does.
So at this time, I'd like to open it up for questions. You're welcome to unmute your microphone and ask a question, or if you feel more comfortable, you can type it into the chat box. Lisa, is that you?
Well, I didn't have a question, so I was waiting for those that did.
Okay.
Hi, this is Leah.
Hi, Leah.
Hi, I have a question. I think Amy was the one who mentioned that, let me just say that my mom is currently in an ALF, a community-based 6-week ALF with 4 residents currently. And Amy mentioned that ADL, part of the ADL protocol, I think is the word she used, was to assist on the telephone. We just got a notification last night that they're going to, of course, we've been following the no visitation protocol, but then we got a notification last night that telephone assist is going to be very much restricted to, like, I think it's an hour in the morning and an hour in the evening, and we can only call during these specific times. So my question is that really legal?
So that's a good question. When I was discussing activities of daily living and independent activities of daily living, I was discussing those in how it relates to care in the home.
Okay.
So to answer and categorizing what long-term care insurance companies consider, you have to have a certain amount of in ADLs in order to qualify to receive your insurance benefits on your long-term policy. So
Okay.
Leah, that's what I was explaining. But to answer your question, and it's a really valid, good one to what's going on right now with COVID. So unfortunately, each facility is dealing with staffing issues and staffing concerns and staffing challenges, and they have the right to say, we can, you know, our first priority, they will tell you, is, you know, caring for your loved one, and they will try as best as possible to have you communicate with your family member as often as, you know, they can handle that. And it's happening. I have heard it happening in memory support units in some instances where they've had to do a 3-time-a-week schedule because they just can't, they just don't have the amount of staff capacity to engage with every client and every family member 3 times a day. The way we're suggesting to people to work around it is with approval, perhaps if it's everything is about like what you can afford and if there's benefit, but perhaps maybe if there can be a private caregiver allowed in, or that person could potentially connect with you on a private level with your loved one. Of course, that person would have to be COVID tested and go through all the same protocols. So I hope that answers your question.
Yes, I mean, and it answers my question in terms of me wanting to call out, but let's just say my mom wants to call me and it's not in that time frame, you know, so maybe she has a concern about something that happened and she wants to call me. So
So this these are the issues that have gotten very complicated during COVID-19.
Yes.
It's become daunting. And so to Amy's point, when, they're having to face staff ratios in these facilities, and there's only so many people hands-on that, can assist patients, residents, to manage the phone.
So I have one suggestion. If you're, I'm assuming that your mother is unable to utilize a cell phone or a landline phone herself. Is that correct?
Well, she has been technically challenged, yes. But that we've already kind of thought about that, yes.
Okay. So the only other option I can think of off the top of my head to give you a help here is perhaps form an alliance with someone in that community, an employee in that community that you could say at the end of your shift, can I, have you help me? You like that idea, Lisa? Okay, so we'll let you weigh in on that. Perhaps form your own alliance with somebody in,
Yes.
maybe not a skilled nurse that is, performing rounds from room to room, but maybe somebody that will assist you so that you can connect with your mother and that person can set up a schedule. I know that that's going on as well.
Okay, thank you, Amy.
All great ideas, and I think we all have to be resourceful and be creative during this time frame. We're going to take one more question or comment. Lisa, I think there was something you wanted to share with today's audience.
Yes, thank you so much. Stephanie, first I have to say to you and Amy and Jill, thank you for that excellent and much needed information. I was going to ask you too, if it's possible, I think you did say we could get a copy of your PowerPoint, because the information you shared, I definitely want to share it with our prospects and our existing residents. But I wanted to speak to everyone coming from a senior living community, Allegro in Parkland, Florida. We're brand new, and pertaining to COVID-19 and testing, we are chock full, well stocked in terms of personal protective equipment, gowns, gloves, masks, all the supplies, disinfectant wipes. Not only do we have those items, but we know how to properly use them because we are providing in-services to our staff. In reference to testing, Jill, you were right on point. We are testing our new residents 7 days prior to entry into Allegro. They have to test negative. Once they come in, they are quarantined. And on day 5, we test them again before they are then allowed to walk about in the community with masks on. Our staff, we're tested every 2 weeks. And those essential vendors that you mentioned, like a primary care provider or a podiatrist or a dentist, they too have to provide paper documentation that they're negative. And then if they have to have subsequent visits, every 2 weeks, they have to provide another negative test. We have a contract with GenetWorks. This is a lab company that Allegro is using, that we have been empowered to be able to get those tests and then to get those tests returned back to us in a timely manner. Visitation window, Leah, you mentioned about being able to communicate with your loved one. We have a visitation window where we have a bench and they can clearly see their loved one, because we realized how important it is for people to have that physical and connection to their loved ones. We have a Wi-Fi program, IN2L, where they can do a Skype, and we have, Amy, as you mentioned, staff that will assist our residents in being able to communicate with their loved one at any time that they want to. We have pendants. They press that pendant, I want to talk to my daughter, and we will get them the communication device that they need. If they don't already have it, we'll provide it for them so they can communicate with their loved ones. So I just wanted to mention those things. And lastly, we're very, very proud of this, and I was able to mention it during a Zoom meeting we had earlier. We have not had one staff person nor one resident test positive for COVID, and that's because of the strict CDC guidelines that we follow. Thank you so much for your time. Please, everyone, be safe and have a wonderful weekend. Thank you, Stephanie.
Thank you, Lisa, for sharing. And I want to thank my co-hosts, Amy and Jill. I hope everybody will join me next Friday, July 17th at 12:30 for our next webinar, Man's Best Friend, How to Create a Pet Trust in Your Estate Plan. You can register by going to the firm's website and filling out the registration form. You'll then receive the GoToMeeting link. And while you're there, download the free document checklist to help you start to organize your thoughts before a consultation. And you'll be able to download a gift certificate as well. So enjoy the weekend, stay healthy, stay safe, and thank you for joining us today.
Thank you. Thank you so much.